us to share.
Okay, yeah, start now.
Welcome to our next webinar in our Lifestyle Medicine series. Today, we are going to focus on strategies to manage substance use. We have three experts joining us today. First, Dr. Joanna Streck is a member of the faculty in psychiatry at Harvard Medical School, and she is a core faculty member at the MGH Health Promotion and Resiliency Intervention Research Program, Tobacco Research and Treatment Center, and Center for Addiction Medicine. She also serves as a staff psychologist at the MGH Substance Use Disorder Bridge Clinic. Her program of research seeks to identify effective substance use disorder treatments with a focus on developing and testing innovative tobacco cessation and harm reduction interventions for populations most vulnerable to tobacco use. Next, we will be joined by Rachel Rosen, a psychology fellow in psychiatry at the Massachusetts General Hospital. She serves as a behavioral health clinician in the MGH Outpatient Psychiatry Clinic and West End Clinic, and as smoking cessation counselor for the MGH Smoke-Free Support Service. Her research focuses on the development, evaluation, and implementation of behavioral interventions for tobacco, substance use, and co-occurring conditions. Finally, Dr. Elyse Park is a professor of psychiatry at the Mass General Hospital in Harvard Medical School and director of the Health Promotion and Resiliency Intervention Research Program at the Mongan Institute at MGH. She directs the behavioral research for the MGH Tobacco Research and Treatment Center and the MGH Cancer Survivorship Program. I will now turn this session over to them so they can educate us on strategies to manage substance use. Thank you all for joining us.
Thank you. Let me go ahead and share our slides. All right. Elyse and Rachel, will you give me a thumbs up if you can see that? Okay, wonderful. Yeah, so we are thrilled to be here today and talk with you all about different strategies to manage substance use. So in terms of a brief agenda, we'll open up the presentation by sharing a little bit of background on substance use among individuals with cancer. Then we'll describe different cognitive and behavioral treatment strategies for managing substance use. And then we will go through some resources at Mass General for receiving smoking and addiction treatment for individuals who are interested in this. And we hope to have some time for a discussion and for you all to ask any questions that you might have, though we did include our emails at the end if anyone has questions that they don't ask today that they prefer to email us. So when we say substance use in this presentation, we refer to the use of a variety of different substances. So that could be nicotine, like smoking cigarettes, consuming alcohol, using cannabis, or using some other drugs in a non-prescribed way, such as opioids or stimulants or any other drugs. We acknowledge that every person who uses substances may have different goals for their substance use. So some may want to change their substance use. Others may want to reduce but not completely stop their use, and some may wish to completely stop their use. So as I mentioned, today we're going to talk about some skills to use if you do want to make changes to your substance use behavior, and then we have some treatment resources for those seeking more help with their substance use at the end. So I'll tell you about some research that our team who's here today has conducted looking at the prevalence of substance use in patients with cancer. So we use nationally representative data from 2015 to 2018, and we found that 4.5% of adults with cancer and 7.9% of adults without cancer had a substance use disorder. So that's a slightly lower prevalence of substance use in patients with cancer. And in this same data set, just looking at cigarette smoking, we found that 15% of adults with cancer smoke cigarettes compared to 24% of adults without cancer. So I'm going to show you those same data in a table, but here on the left-hand column, we break down by each individual substance use disorder ending with cigarette smoking, and each column is a different population. So this is individuals with cancer, this is individuals without cancer. So you can see the stat I just told you about, where we see about 5% of patients with cancer have any substance use disorder compared to about 8% in people without cancer. So again, a slightly lower prevalence. What I found interesting was that for opioid use disorder, we see equal prevalence rates of opioid use disorder across individuals with and without cancer. For all the other substance use disorders, we generally see a lower prevalence in people with cancer compared to those without cancer. And then this is the number I already told you about of prevalence of cigarette smoking. So to go into more detail about the prevalence of tobacco use, since there's many types of tobacco use besides just smoking cigarettes, we used a different data set to look at the prevalence of different types of tobacco use among people with cancer. So I've broken this down by individual product type. So here we see cigarettes, similar prevalences to what we observed in our last data set, but we see that cigarette smoking is the most common form of tobacco use in patients with cancer compared to all the other types of use here. And I should have mentioned that these two columns are different time frames. So this is since a person has been diagnosed with cancer, and this is in the past 30 days, but this whole sample has cancer, unlike the last sample that we saw in the prior slide. E-cigarette use, which we know has the prevalence of e-cigarette use has risen in people with and without cancer. We see a lower prevalence of e-cigarette use in this population of people with cancer. So about 2% of people report using e-cigarettes since they were diagnosed with cancer. And then the last thing I'll draw your attention to is that we see that some people are using multiple cigarette products together. So this is using cigarettes with any other alternative product listed in these categories. And we see about 5% of the sample is using cigarettes plus another tobacco product, or 5%, almost 6% overall of using any combination product. So taken together, we see that patients with cancer do smoke cigarettes and use other tobacco products, including new and emerging products like electronic cigarettes. So why address substance use in cancer treatment or in people with cancer? We know, and there's a lot of data showing that following a cancer diagnosis, non-prescribed use of substances, including cigarette smoking, is associated with negative mental and physical health outcomes, including the development of secondary primary tumors, increased risk for mortality, other decreased quality of life. And we also have evidence that combined use of substances, so for example, using alcohol with tobacco, can have multiplicative impact on risk, meaning that it could increase your risk further than just using a single substance and increase your risk for cancer and other adverse outcomes. So stopping substance use can greatly improve cancer treatment course and health outcomes and improve quality of life. So I will now turn it over to Dr. Park to tell you all a little bit more about the benefits of quitting smoking for individuals with cancer who smoke cigarettes.
Thank you very much, Dr. Streck. I'm going to briefly give an overview and talk a little bit about why we intervene with individuals who are tobacco users after their cancer diagnosis. Recently, in the past decade, there's been a great increase in the amount of data we have about why it is important to cut back or quit smoking after a cancer diagnosis, and more importantly, why it's important to be communicating with clinicians about this. There are great benefits and risks of continuing to smoke after a cancer diagnosis. The good thing about this work is that by changing your smoking behavior, cancer patients can improve their treatment outcomes. So the biggest benefit of quitting smoking after a cancer diagnosis is for across surgery, radiation therapy, and chemotherapy. Individuals who quit smoking after their cancer diagnosis have potentially better experiences after their surgery, decreased rates of complications after their surgical treatment. For radiation therapy, quitting smoking can actually help decrease treatment toxicity of the chemicals used in radiation therapy. And then in chemotherapy, smoking can reduce the efficacy of some chemotherapy agents. So actually quitting smoking can improve the power of these agents. Next slide, please. Next slide, please. Thank you. So in 2014, almost a decade ago, the updated Surgeon General's report came out. This was really a landmark issue where there are conclusions directly linking tobacco treatment and cancer treatment outcomes. And what this report concluded was that in cancer patients and survivors, the evidence is sufficient that there is a causal relationship between cigarette smoking and the following outcomes. Adverse health outcomes, meaning quitting smoking can improve your health outcomes post-treatment. Link between the causal relationship between quitting smoking and increased all-cause mortality and cancer-specific mortality, so overall improving your health and mortality outcomes. The last is increased risk for second primary cancers, so that quitting smoking will help decrease the chances of getting a second primary cancer. There was associative research, but not definitive research, that quitting smoking can help decrease the chances of a cancer recurrence, and that is to be determined in likely later publications. Next slide, please. So oftentimes, despite this emerging evidence, then what we see is tobacco use is not usually addressed during cancer care. We do a lot of work with clinicians and trying to bring in these conversations into treatment, but there's multiple reasons why across patient, clinician, and systems-based barriers. One is patient barriers. Sometimes patients are distressed or perceived to be too distressed to address smoking around that time. There's a stigma, particularly patients with smoking-associated tumors. They have concerns that they, if they bring up smoking, there might be some negative implications, maybe within treatment or outside of treatment. A sense of helplessness, feeling like once they've gotten cancer, there's not that much to do. And overall, just addiction, that most patients who continue to smoke after cancer treatment are highly physically addicted. There's also clinician barriers. Sometimes clinicians don't feel they have the training or referral options for patients, or they don't believe that patients really want to quit. The last is systems-based, where there's an inadequate identification of smokers. It's very hard to track smoking status. It's a variable that changes often, so to consistently have it updated and tracked in the EHR is difficult. And also, there might be some concerns that it might be costly to deliver tobacco treatment. We've created interventions across all of these barriers, and we're hoping to move the needle in helping patients feel more empowered to try to make smoking change behaviors. The clinicians feel more empowered to have these conversations with patients. And we've done a lot of work in creative-based, systems-based interventions, really showing the cost effectiveness of delivering these interventions and helping clinicians keep updated electronic medical records on patients' smoking status. Next slide, please. So counseling, tobacco counseling delivery has some key ingredients, and I just want to touch upon it. Tobacco counseling delivery for cancer patients is similar to evidence-based tobacco counseling for non-cancer patients, but it's often targeted so that we can address the needs of patients during treatment and after treatment due to their busy schedules, stress levels, health concerns. The first is motivational interviewing in terms of type of counseling delivering style. Motivational interviewing is strategic question answer based counseling, where it's very patient based, trying to elicit patients' reasons for making a change. Cognitive behavioral therapy helps patients really problem solve and work to have solutions to behavioral cognitive barriers to making behavior changes. And positive psychology is a newer form of treatment where we really try to elicit patients' strengths and areas in which they feel that they have the power to make the changes. We have protocols structured according to quit readiness. We know that smokers come in very different types of presentations, and some individuals who smoke are not ready to quit and some are. And so we have counseling that's tailored to that. In our program that we currently have at the Cancer Center at MGH, that's free to all patients, we have virtually delivered tobacco counseling. It can be delivered by the phone or via video, so patients don't need to come in. Tobacco counseling is brief. People do not need full hour sessions. Oftentimes, they need 10 to 15-minute check-ins on their journey to making behavior changes or quitting. And last, it's really important that it's cancer targeted to their treatment regimen, to the to potentially the side effects that they're having from treatment, and to any stress caused. Next slide, please. Medication options is also really important, as research shows, to combine behavioral treatment with medication treatment. These are evidence-based strategies of medication treatment for patients who are undergoing cancer treatment and tobacco treatment. Nicotine replacement therapy comes in the form of the patch, which is a physical medication that is placed on an individual. The lozenge itself is something that patients can take as needed, as well as gum. Often people like a combination of the patch and the lozenge, or the lozenge and gum, because the patch stays on and lozenge and gum can be taken as needed. Varenicline is a smoking cessation medication that's taken in the form of a pill. And bupropion is a medication that was actually originally created as an antidepressant, but has also been found to be very effective in helping people quit smoking.
All right, so now I'm going to introduce some terms that will come up in the next part of the presentation and give a little bit of a flavor of what treatment could look like and how people can maybe think about making changes now on their own if they wanted to, or to be able to understand a little bit more about what happens. So the first term is craving and urge, and these are sometimes used interchangeably. And this is really just a strong desire to use a substance. It could be tobacco or alcohol or any other substance. And this could be in the form of a thought, like I want to use right now, or I have a desire to use. It could be in the form of a mental image, like picturing yourself with a drink or picturing yourself with a cigarette. And it could also be a physical sensation. So noticing like a tightness in your chest or a tingling in your throat. We also will be talking a little bit about triggers, and triggers are things that lead to use or that increase someone's risk for using. So sometimes people will talk about people, places, and things that are associated with use. These can be both internal triggers as well as external. So internal triggers are things like stress or emotions, as well as thoughts or even things like physical pain. And external triggers are things that are outside of our bodies, like being in certain places or around certain people, or even sometimes the time of day, like first thing in the morning or the evening. We'll also talk about a couple of different types of thoughts. So we'll talk about automatic thoughts, and these are thoughts that can just kind of pop up into our mind without our awareness. They're sort of hardwired in us in a way. And we'll also talk about cognitive restructuring, which is a strategy or practice of trying to respond differently or change some of the automatic thoughts that come up. Next slide. So now I'll talk about some of the specific skills that we use in treatment to manage substance use in people with cancer or without cancer, and describing this through a cognitive behavioral frame. Next slide. So I've been talking, and other speakers have been talking about the cognitive model or cognitive behavioral therapy, and I'll just describe this in a little bit more detail. So when we talk about cognitive behavioral therapy, we're really thinking about a model that helps us understand the relationship between our thoughts, our feelings, and our behavior, as you can see in the picture to the right. And so feelings briefly are our emotions or physical sensations that we have in our body, things like our heart racing or noticing tension or tightness. We also have thoughts like the running commentary in our mind or the things that just pop up in our head. And then behaviors are actions that we engage in, things like using a cigarette or using other substances. It could be other kinds of behaviors as well. And through the cognitive model, we can understand how the three of these components relate to each other and can influence each other in multiple different directions. Often people are only aware of or mostly aware of their feelings. So they might notice that they're having a hard day or they're feeling kind of down, but don't really have as much awareness or attention to the things that are running through their mind or the ways that they respond to these different feelings. So part of our job is to try to build some awareness and then be able to intervene or address these different areas, often focusing mostly on behaviors and thoughts, since those are some things that we can change a little bit more easily than the way that we feel. Next slide. So I mentioned that we want to start by building awareness. If we're not aware of how our thoughts are looking or what our emotions are or what our behavior is, it can be really difficult to actually change anything. So one of the first steps is to try to build our awareness. And one strategy that we have that has a lot of support for helping with behavior change is a self-monitoring log. So the way that this works, and I'll orient you to the picture on the screen, is that we ask that people start to take note of and log the different experiences that they have, across those three different components. So they'll maybe report things like the behavior, like what cigarette they're smoking or when they're smoking a cigarette, as well as what's going on around them. And then they'll be able to report the emotions that they're experiencing. Maybe they're feeling stressed or anxious or just tired, maybe bored. And then some thoughts that they might be having, like, I can't cope right now without smoking, or I really want a cigarette. And over time, we can start to look at some patterns and try to understand what is maybe getting in the way of not smoking, and also what we might be able to do to change, again, some of these behaviors and some of the thoughts that come up most often that contribute to the emotions that we're not comfortable with or that are not helpful, and be able to change our behavior. Next slide. So, as I mentioned, one of the areas that we might be able to intervene is with our thoughts. So I'm going to describe some basics about cognitive restructuring. And so just as a reminder, cognitive restructuring is a practice or skill of being able to notice and change or respond differently to unhelpful thoughts that we might have automatically. And it can be really helpful to remind ourselves that our thoughts are our interpretations of situations or experiences, not necessarily accurate and not necessarily facts. And keeping that in mind can sometimes help us be a little bit more compassionate with ourselves, or a little bit more able to distance from thoughts that we don't find helpful or that don't serve us in a certain situation. And one category of automatic thoughts are negative automatic thoughts. And these come on also automatically, sometimes without our awareness. And usually they're not helpful. They don't help us to either behave or feel in ways that are that we like or that we want to be. So now I'll go through some steps for how we can actually do the practice of cognitive restructuring. So once we've been able to monitor our thoughts a little bit with our self-monitoring log, we can really kind of pay attention to the specific unhelpful thoughts and the emotions and behaviors that come along with them. And then the next step is to start to modify the thoughts that don't feel helpful or that are getting in the way. And so there are a couple of different types of thoughts, and we'll go into those a little bit more later, that we can think about, different categories of thoughts that we might notice. But we want to try to act like a detective or a scientist to try to think about what might be either untrue or not so helpful or wrong with the thought that I have, and how can I try to look for maybe an alternative or different way of thinking about a situation. Next slide. So I'll walk through an example of how we might sort of notice an experience of the relationship between these three components, and then how we might actually do the practice of cognitive restructuring. So let's imagine that the situation is that I'm at work and I'm noticing that I'm having a bit of a tough day. I maybe just got some negative feedback or some, constructive or not so constructive criticism from my boss. And so the automatic thought that pops up into my head is, I just can't handle the stress at work without smoking. And when I notice that thought, I start to feel a bit sad, overwhelmed, and I smoke. And that helps me to sort of manage in the moment some of what I'm feeling. But if my goal is to not smoke, then I might want to take an alternative approach. Next click, and have an alternative or restructured thought. So maybe in that situation, I might notice the thought that I have, which is, I can't handle this, and instead try to replace it with, the stress at work is really unpleasant, but actually I can tolerate it without smoking. And when I do that, my emotion might also shift, and I might feel slightly more content or calm or capable. And instead of smoking, I might be more well-equipped to take a walk instead of smoking. Next slide. So we wanted to highlight a few common thinking traps or patterns of thinking that can sometimes get in the way of being able to engage in behaviors that are helpful. And so sometimes identifying these different patterns or categories of thinking traps helps us to notice them more quickly and respond to them in similar helpful ways. Next click. So one category of thinking traps is black and white thinking or overgeneralization. So here we're really thinking about or identifying thoughts that seem very extreme on one side or another, and not considering some nuance or some gray area in between. So I smoked when I didn't want to, which means I've failed. And being able to notice that can help us to modify or manage the thought a little differently. Maybe it's the case that I smoked and I didn't want to, but it doesn't necessarily mean I failed. I maybe just had a little bit of a misstep and I can get back on track. Next click. Another category that's really common is a should statement. And just like the name says, these are statements that have the word should in them or shouldn't. So for example, I should have quit years ago. I should have done better. And sometimes we can notice these thoughts a little bit more easily because of that core aspect of them, having that word should in them. Next click. And so as Albert Ellis was quoted saying, you should stop shoulding on yourself. And so trying to just notice when you have this should statement, and again, giving yourself a chance to either change the way that change the thought or try to manage some of the expectations that you have in a different way. Next click. The last category that's common is jumping to conclusions. So a thought might be, I didn't meet my smoking goal this week to throw out the cigarette pack like I wanted to, so now I'm never going to be able to quit smoking. So here we're noticing that people might be getting a few steps ahead of themselves. Just because I didn't throw out the cigarette doesn't mean that I'm never able to quit. And maybe I just need to set a smaller goal, like putting the cigarettes in a different room or giving myself a bit more of a chance to be successful. Next slide. So a few tips for restructuring unhelpful thoughts if you want to give this a try yourself. You can ask yourself some of these questions to try to understand if the thinking that I am engaging in is either not so helpful or is maybe representing some untrue thoughts that I have. So one question is, what's the evidence that the automatic thought is not true? We're often very good at finding evidence that our thought might be true, but sometimes it can be helpful to think about what the evidence is that my thought is maybe not so true or not so helpful. Another question to ask yourself is there an alternative explanation or another way of thinking about this? And in particular, is there another way to think about this that might be more helpful in this situation, that might allow me to change the way that I feel or change my behavior in this situation? Another question that we can ask ourselves is, what's the worst that could happen and how could I cope? Sometimes people worry that their worst outcome will happen, and not only that, that they can't handle it. And so we want to give ourselves a chance here to try to understand really what is the worst thing. And if it did happen, what would I be able to do to get through it? And another final question to ask yourself in these situations is, if my friend or my child or my sibling or somebody that I'm close to was in the similar situation and they had this not so helpful thought or thought that I'm having, what would I tell them? And people find that they're often quicker and have an easier time to support other people when they have thoughts that don't feel so helpful or don't necessarily reflect the reality, and have a harder time turning that toward themselves. So this is an opportunity to try to understand how I might respond to somebody else. Next slide. So the next step, if we think about that initial triangle, we can start, of course, by paying attention, having more awareness. And then we can think about how we can change our thoughts. Another way that we can start to change our substance use behavior and the patterns of substance use behavior is by actually changing the behaviors themselves that might make us more likely to engage in substance use behavior. So if we are able to increase our awareness of the kinds of situations or the kinds of triggers that we are that are more likely to increase our substance use, we can start to do something different with them. So if you remember, a trigger is something that increases the likelihood that I might use or something that's associated with substance use. And often what happens is there's a trigger that we may have awareness of or we may not, and that sometimes will kind of contribute to an urge or a craving. Again, that could be a thought, an emotion, a physical sensation, and that can sometimes lead to smoking or drinking or other substance use. And so if we're able to build awareness of the kinds of triggers that increase our use, we can try to do 3 different things to manage them. One of the first things that we can do is try to avoid the trigger altogether. So maybe if I'm trying to cut down on my alcohol use, I could actually skip going somewhere where I know alcohol will be served. And that will decrease the likelihood that I'll have an urge to drink, and then also decrease the likelihood that I actually drink. And this is great for triggers that we can avoid and that we can kind of prepare for in advance and know about, so that we don't have to face the trigger at all. Sometimes that's not the case, and we can't totally avoid the trigger, but we can do something to change or modify it. So the second one is to exactly do that, change the trigger or modify it. So if, for example, I want to go to this gathering, or I have to go to this gathering, or I'm choosing to, rather than avoiding it altogether, I might go and choose to keep a non-alcoholic beverage in my hand. Nobody else will know necessarily what I'm drinking, and it might make it even less likely that somebody will offer me a drink or that I feel the urge to actually go and get one. And finally, if I can't avoid the trigger, or I don't want to, and changing the trigger or modifying it isn't possible or doesn't work, I can escape the situation and try to leave altogether. And so in this situation, that might involve leaving a gathering early, choosing that that's the best way to decrease my likelihood of using, because if I leave, I might be less likely to experience that urge and less likely to drink or smoke. Next slide. Another slide here on how we can change the behavior. So if we get to the point where we're not necessarily able to manage the trigger completely, and so we might experience an urge that might still lead to smoking or drinking or other substance use, we have some strategies that we can use to manage or help us with the actual urge itself. So one thing that's really helpful for people to keep in mind is that urges are time limited and they decrease in intensity over time. So urges, when people experience them, sometimes feel like they're going on forever. And it can be really helpful to remind yourself that urges or cravings have to stop at some point, and usually much quicker than people realize once they start to pay attention to it. So just like feelings, where a feeling doesn't typically last for a very long time or forever, we can imagine that our urges will also change. And as people experience longer periods of abstinence, the intensity of each individual urge will also go down over time, as well as the frequency of them. If you do experience an urge, there are a few different types of strategies that we can use to manage that experience. First are some behavioral strategies, and we can use the 4D acronym to try to remember these different strategies. So if I experience an urge and I want to try to interrupt the behavior of smoking or drinking or other substance use, I can first try to delay my use. And so not necessarily telling myself I can never use again, or that I can't have what I am having a craving for, but to delay and reevaluate in the future. Sometimes people have an easier time saying, I won't smoke right now, or I won't drink right now for the next 5 minutes, and a little bit of a harder time saying, I won't smoke or I won't drink ever. And so giving ourselves a chance to delay, to notice that that urge might come down, might allow us to be more successful with not using in response to an urge. Another strategy is to drink water. Similarly, sometimes having an opportunity to interrupt that connection between urge and behavior can be really helpful. Another strategy is to take deep breaths, and we'll talk a little bit more about that as well in a couple of slides, how we can use breathing as a strategy for managing cravings, as well as managing stress in general. And finally, we can use distraction, jumping into something else that will take your mind off the urge or the craving to smoke or to use. And that can take lots of different forms. It might be throwing yourself into an activity. It might be contacting somebody that you trust or that you can talk to. It might be scrolling on your phone, anything that can take your mind off of the urge for a short period of time. We also have cognitive strategies. So these are different strategies that we can use, similar to changing our thoughts or cognitive restructuring, that help us to manage the urge in the moment when we have it. One is urge surfing. And this is a practice that, a mindfulness practice that allows people to respond in a slower, intentional way to an experience of a craving or an urge. So oftentimes, people don't have as much attention or awareness to what the experience of a craving even feels like in their body or in their mind. and being able to, without judgment and without reactivity, to just sort of take a look at what the experience of an urge or a craving feels like can help take some of the pressure off to respond in any other kind of way. So what this might look like is noticing the urge and being able to follow where you feel it in your body, what's going through your mind, and not judging or responding to it in a way that is judgmental, rather noticing what the experience is. And again, kind of slowing your body down and noticing that the urge will also change over time and hopefully reduce. Another cognitive strategy, a similar kind of cognitive restructuring approach, is to allow yourself to take one urge at a time. So rather than focusing so much on quitting forever or stopping forever or committing to something for a really long period of time, it can be helpful to give yourself a chance to deal with the current moment that you're in and take it right now as it is and worry about the next craving or the next urge when you get to it. Next slide. So there are some different strategies, and the links are available if folks want them. But here's just a very quick video, if we can get it to work, that shows a practice of diaphragmatic breathing or deep breathing that can really help regulate both our physiology as well as our mind.
What I'd first like you to do is put one hand on your chest and one hand on your stomach. And we're going to take 3 deep breaths, just normal deep breaths. Good. And did you feel that top hand really moving as you breathe? And when we're stressed, that tends to be the type of breathing that we engage in, is that chest breathing where the shoulders rise and fall and there's some tension there. So when we do diaphragmatic breathing, we're going to push that breath down lower into the stomach. And instead of that chest moving, it's going to remain nice and steady while your lower hand rises and falls with your inhale and exhale. So as we take a breath in and out, you're going to breathe in through your nose and then out through your mouth, slowing that breathing down and letting that air fill your belly as it goes down through the chest and expanding the belly. And then as you exhale completely, your belly is going to let go of all that air and completely exhale out. And your breath in will be about 4 seconds. And your exhale will be a little bit longer at 6 seconds. So we're going to practice. And we'll do about 3 breaths with me guiding you. And I'll say inhale, 2, 3, 4. Exhale, 2, 3, 4, 5, 6. That exhale is a little bit longer than the inhale so that we're getting all of that byproduct of our breathing out. The inhale will be nice and steady and a nice steady exhale. So you can close your eyes and get comfortable. And when you're ready, we'll take that first inhale, breathing in through your nose. Inhale, 2, 3, 4. Exhale through the mouth, 2, 3, 4, 5, 6. Inhale, 2, 3, 4. Exhale, 2, 3, 4, 5, 6. Inhale, 2, 3, 4. Exhale, 2, 3, 4, 5, 6. And I'd just like you to fall into a steady pattern of breathing, continuing to breathe deeply.
So I'll just add one last comment about the breathing. You've had this great tutorial from the folks here on this video. If folks are having difficulty doing this type of breathing, I sometimes recommend that you lay down to do this practice. This is how our bodies sort of breathe naturally when we're sleeping or when we're laying down, and that can sometimes help us direct that breath a little lower. And also using some imagery, we can maybe imagine that we're taking a breath into our stomach and trying to blow up a beach ball or a balloon that's down there. So those can be some strategies to manage or enhance the breathing that we do. I'll pass it back over to Dr. Streck to continue talking about some strategies as well as resources for managing substance use with supports at MGH.
Thank you. Just see if I can get to the next slide. All right. So before we get to the treatment resources, we just wanted to make a note about the importance of several other factors for reducing or stopping substance use and preventing relapse. The first that we did not cover as much today because we focused on behavioral strategies is medication. So for a lot of substance use disorders, a combination of behavioral therapy plus evidence-based medicine is the most efficacious approach. So if you're seeking treatment for your substance use, we would really encourage you to work with prescribers and physicians to make sure that you are being offered the evidence-based medicines for these conditions. Social support is also very important, seeing how you can maximize friends and family that support your goals with your substance use, which in turn can help support an environment that is friendly for your recovery, and how to problem solve around people who might not be supportive, and how to make that best work for you and your recovery for substance use. And then lastly, and as is the theme of this seminar series, having an overall healthy lifestyle, practicing different stress management strategies. I think previous seminar sessions have covered things like nutrition and physical activity, and I think the next session will be on sleep. And so all of these different factors are very important for creating a healthy lifestyle that supports your substance use goals. So before we get to the Q&A, the last thing that we wanted to share with you all is all of the substance use treatment resources available to you at Mass General. The first is specifically for tobacco treatment or smoking cessation. This is a service that Elyse Park directs and developed at the Cancer Center based on her research on smoking cessation in patients with cancer. And Rachel Rosen, who you just heard present, is actually one of the clinicians in this service. So if you are seeking smoking cessation treatment and looking to quit tobacco, you can contact the Smoke-Free Support Service and get free virtual one-on-one tobacco counseling and medication recommendations, which we saw in Elise's presentation. So we have the contact information here, and our slides will be posted so you can have all of the information that we presented today. Now, for non-tobacco substance use, MGH has a ton of substance use treatment resources. There are various substance use clinics depending on your age and kind of where you're at in the recovery process. The Bridge Clinic is for individuals who are higher risk and are not yet ready or able to connect to longer-term community-based care. So you can see our phone number here, and you can also just walk into the clinic. It's a low-threshold clinic. And then the West End Clinic and Arms are outpatient practices for addiction treatment and dual diagnosis programs for psychiatric and addiction treatment for individuals who are adults. In the case of the West End Clinic, and Arms or Addiction Recovery Service is for young adults and children and their families, or their parents, I should say. And then lastly, we have the Hope Clinic, which is for individuals who are pregnant or postpartum, and for their infants and their families. So all of the numbers are here, and if you're looking for treatment, feel free to call, and any of the individuals at these clinics can guide you to another clinic and guide you to any resources that you need. So that's the end of our presentation. Thank you all so much for being here and for listening. If anyone has questions, we'd love to take and answer any questions if you have them, maybe through the chat. I don't know how that works, Amy.
Yeah, so we encourage participants to put their questions in the chat or the Q&A box, whichever one is working right now. But I can pose a question that I think comes up a lot in my own clinic sometimes. And, sometimes, let's say an individual, for example, is smoking or perhaps drinking excessive alcohol, et cetera. And it's really the family member who's worried about that person, but maybe the patient herself is not really ready to make that change. What is some advice that you shared such great resources and strategies, but what are some advice to maybe work with the patient and the family member to help that individual be ready to make that change?
Yeah. Yeah, I would say that kind of meeting the patient where they're at might be the best first step. Typically, rolling with resistance is a better way to help someone get more ready versus trying to force or push someone, which usually leads to the opposite effect. Once people are in treatment, and the Bridge Clinic resource that I showed, for example, is for individuals at all stages of change and recovery. So some folks we see there are there for harm reduction, not ready to completely quit. So that might be a good place for someone to start who isn't yet ready for an abstinence-based approach. In all of these clinics, they're very skilled in working with families. So a lot of times in these clinics, we have family sessions and help educate family members on, for example, medication treatments, because I think the parental and family worry is very important. And there's also, I think, a lot of misconceptions about addiction treatment that can sometimes cause family concerns that can be remedied by family sessions and visits.
Thank you. That's very helpful. Appreciate that.
Thank you.
Certainly, we open it up for other questions. I did note, for example, the tobacco counseling service, and perhaps one of you like to speak to this, that it's also available in Spanish, which is really amazing.
Yeah, our intervention was offered in Spanish, and we do a lot of work with the MGH interpreter services now for other languages as well. And it's open to anybody who's had any kind of treatment at the cancer center. They don't have to have had their primary cancer treatment. If they get their primary care at MGH, that's fine as well. I'm sorry, it's open up to any MGH patients who've been treated for cancer, but they don't have to have had their primary treatment at the cancer center. And it's for patients who are at any point post-diagnosis as well, or post-treatment.
That's such a great resource. And certainly, I know I see patients at different sites, not just in Boston. And I know you've made this available to patients throughout the MGH Cancer Center network, which is really wonderful. So thank you for having this resource for our patients. I know I'm not sure if I see any other questions right now, but I'm curious if you have other words of advice. Sometimes, I'll give an example. Like, I always ask my patients about if they smoke cigarettes, if they drink alcohol, if they use other drugs. And as we know, as a breast oncologist, it is very common that many of my patients do have, 2 or 3 glasses of wine each night. There has been sort of a health halo around, maybe not 2 to 3 glasses of alcohol, but certainly, this thought that drinking some wine is good for our cardiovascular system, et cetera, although that recent paper dispelled that. But what are some good strategies? I certainly have my own strategies I use in clinic, but when you're really trying to help a patient cut back on alcohol, maybe she's only having, 2 drinks a night, but we know that's really not great in terms of her cancer. What are some ways you would suggest discussing that with a patient? Because I certainly never want an individual to also feel that somehow she was drinking too much and this caused her breast cancer.
Yeah, I think that is a really, important point, that the issue of drinking in moderation is one that there are a lot of different opinions around. There's a lot of conflicting data around. And I think the best, provider approach of where to start that discussion might be around just assessing the patient's goals and doing more like motivational interviewing around, I see on this questionnaire that you note that you have 3 glasses of wine a night. How is that going for you? Is there anything, how is that feeling for you? Are there things that you're looking to change, and kind of assessing where they're at for you to guide where you want to go with it? I don't know if Elyse and Rachel, you have any additional thoughts.
I can jump in with another thought and then see what's left. I think sometimes it can also be helpful to sort of ask for permission from the patient to have a conversation about things that they may or may not want to talk about, or may or may not have ever been asked if they want to talk about. So for example, might take the opportunity to say to a patient, you know, you mentioned that you have a few drinks each day. I have some thoughts about it, or have some information I wanted to share. Would it be okay if I shared that with you? And kind of honors the patient's autonomy and participation in that discussion. And I haven't personally had experiences where patients have sort of flat out rejected invitations for these kinds of conversations. I think we worry about it more often than it happens. And so that can sometimes allow for kind of a mutual discussion that they feel like they are participating in fully, and then to share information in a way that feels both educational and person-centered, and then to ask for their feedback about it, and to sort of say, like, what do you think about that? Or how did, like, what did you know about that? Or how does this sound? And that can sometimes open the conversation up a little bit more as well.
Good points.
I agree. I think also that's part of, in motivational interviewing, the strategy Rachel says actually called elicit, provide, elicit, where you give them information, you kind of ask their permission, you provide information, and then ask what they thought about that. So thank you for naming that, Rachel, too. The other piece is that when we address, what's really important is when we address these behaviors, it's not, we don't address them individually. The patient sees them as part of their overall comprehensive cancer treatment. We try to treat the whole patient. So we try not to say, we're going to treat your stress and your alcohol and your cancer. It's all part of the same deal. And so patients don't feel overwhelmed that something additional, rather it's actually a part of our treatment. And then they can choose not to participate in that part of treatment. But I think presenting it as, again, comprehensive quality care is really important.
And nice for normalizing it versus stigmatizing it as a separate issue. Yeah, that's such a good point.
I really like all of your comments. Those are really great. And I think just excellent points to think about as we conclude our webinar today. So thank you all for participating and for educating us. And so glad that this will be available to those who would like to watch it in the future. So thank you and have a wonderful day. Thanks.
Thanks for having us.